So, good evening. My name is Tim Gibbs. I'm the Director and PI for Delaware Health Force. Delaware Mini Medical School is a program of Delaware Health Force, which is funded by ARPA, American Rescue Act, Planning Act funding, and local funding. If you have a problem with Zoom, hop on over to YouTube streaming. Go to youtube.com/Delamed302. Just do email and Sabine, that's Nicole Sabine at delamed.org, and she'll make a note that that's how you attended the class. Wanted to let you all know this is the new slide, the National Public Health Week, which is sponsored by the American Public Health Association, of which we are Delaware's affiliate, happens between April 7th and the 13th of this year. And during next week's session, we're going to talk about how you can get involved on social media and even potentially win a prize. I don't know that we figured out what that prize will be, but we tend to do pretty good prizes, so it should be worth your while. Just to remind that we don't use the raised hand feature. Please put any questions you have into the Q&A. Just the housekeeping tips. This is a Zoom webinar, not a Zoom meeting, so you can't see or communicate with your fellow classmates. Use the Q&A feature. Don't ask questions of a personal or family nature. We will do our best to answer all questions, either by staff of their housekeeping or fairly generic medical practice or by our presenter. When can you leave? You can leave when the presentation is officially done and you'll be counted as being here. Once we get into the Q&A, and you'll know when that is, at that point you can leave. We've heard so far about respiratory therapy and last week about becoming an emergency medicine physician. And this week, we're going to hear from somebody who is an emergency medicine physician. And I'm going to turn it over to my colleague, Christy Handley from the Sussex County Health Coalition, to introduce this evening's speaker.
Great, thanks, Tim, and welcome to everyone. And thank you, Dr. Sanchez, for joining us today. Dr. Sanchez is a pediatric emergency medicine physician at Nemours Children's Hospital in Wilmington, Delaware. She completed her pediatrics residency at Baylor College of Medicine, Texas Children's Hospital in Houston, and her emergency medicine fellowship at the University of Texas at Austin, Dell Children's Medical Center. Dr. Sanchez is passionate about medical education, simulation, pain management, and patient safety, and has received multiple awards for her excellence in teaching. Her current research interests are improving patient resuscitation outcomes via the use of mobile phone apps and implementing early feeding in patients with respiratory failure from bronchiolitis. Dr. Sanchez is looking forward to sharing her research at a conference in Germany this May. She is co-director of the Medical Student Pediatric Emergency Medicine Clerkship, and when she's not taking care of patients, she is home with her husband or at Starbucks or with her two dogs, Simon and Murphy. Dr. Sanchez loves learning and is often heard telling her patients that she has the best job in the world. And we welcome you, and we're looking forward to hearing from you tonight.
Thank you so much for the introduction. Is it okay if I share my screen?
Yes, ma'am.
Hi, everyone. Thanks for joining. Can you see?
There you go.
Hi, my name is Amani Sanchez. At work, I go by Dr. Sanchez to patients. And I am super excited to talk to you guys all about what life is like as a pediatric emergency medicine physician. I know you talked to some of my fellows who I work closely with last week, and they've talked to you about how to become a pediatric ER doctor, but I'm here to give you a real perspective on what it's actually like. So my name is Amani. I work at Nemours Children's Hospital. I'm a pediatric emergency medicine physician. I'm a supervising attending, which means I'm one of the lead doctors. There's a large group of us. And I'm also clinical assistant professor of pediatrics for our local medical school. So who am I? I'm a board certified pediatrician. I've completed pediatric residency, and I am a board eligible pediatric emergency medicine physician. So I've completed pediatric emergency medicine fellowship, and I am taking my boards this year because they're not offered every year. So I'm waiting for them to come up this year. They're coming up in April. I'm a pediatric emergency medicine attending, which means I'm a pediatric ER doctor, and I'm a clinical assistant professor of pediatrics. And I am a clerkship director for the medical students that come from our local medical school or other medical schools that rotate in the emergency room at Nemours Children's Hospital. I help coordinate their visits and their time with us, and organize their rotations and teaching and all that fun stuff. And I'm a mentor to many medical students and fellows. But aside from my clinical work, I am also a wife, a dog mom, a sister, a niece, a friend, a teacher, and a learner. And these are pictures of my best friend and my family. And these are my dogs, Simon and Murphy. Oh, my slides stopped flipping. Oh, okay, we'll do it that way. This is Simon, this is Murphy. They're a big part of my life. We go on many walks, and it's part of my life as an ER doctor. So why did I decide to be a doctor? I decided to be a doctor because, first off, my mom was a pediatrician. She's a single mom, and I grew up pretty much my whole life with her in her clinic, kind of helping check patients in and being around little kids that were sick. So I kind of grew up in the pediatric world. And I always loved medical shows. Growing up, I was just super excited to watch medical shows all the time. And I really thought it was interesting and loved learning about the human body. And I've always loved to use my brain. I've always been really curious about all the things that are going on in the world. And I find that being a doctor is something that I use my brain for all the time. And then what else? Being a doctor's career stability. So pretty much no matter what, no matter where I am, I'm always going to have the opportunity to have a job, whether it's in pediatrics as a general pediatrician, working in urgent care, doing pediatric ER care at a hospital, or even doing other things like consulting. And then why be a doctor and not a nurse or a nurse practitioner or a physician assistant, respiratory therapist? There are all these other awesome parts of medicine and ways to get involved. Mainly because I wanted to be the team leader. I wanted to be the one ultimately in charge of my patients, and I wanted to be the one making the decisions at the end of the day. So before medical school, I kind of took an unusual path. I grew up in Southern California, and I went to University of San Diego for college. And I actually I have a bachelor's in political science, and my minor was in theology and religious studies. So a little kind of atypical career. And I actually took 6 years off due to some family tragedies. So worked for a long time at a restaurant as a server, and then I worked in a chiropractic office as a chiropractic assistant. And after being off for 5 years, I decided that the time was right. I'm going to start getting my ducks in a row to apply to medical school. And it'd been so long that I had to take an extra year of classes. And so after that year of classes, I applied for medical school. And some things that I think helped me get in was that during college, I did a study abroad in England, and a lot of people really liked that I had this experience outside of my typical everyday life and was able to interact with people of, a totally different country and other cultures. In college, I was involved in multiple clubs, and I even founded a multicultural club, which a lot of my admissions counselors and people asked me in my interviews. Some other things I did were volunteering. So I had a committed volunteer job, and I went every week for many years and volunteered at a children's hospital that not only gave me the volunteer experience that I could put on my application, but it also gave me a lot of interaction with pediatric surgeons and pediatric cardiologists and other kind of doctors and nurses and people who could talk to me about life in medicine. And this volunteer opportunity also luckily granted me a scholarship, which paid for half of my medical school, which was pretty cool. And then I think the other things that helped me get in was that I shadowed a doctor pretty consistently for 2 years, and I got a really great letter from this doctor that helped me get in to medical school. I had a full-time job, which, with my 5 years off, I had worked 6 years off by the time I got in. I'd worked a full-time job and had a lot of life experience, and people asked me a lot of questions about that and kind of saw me as a mature applicant. And I applied very broadly. I applied to a wide variety of medical schools all over the United States. And I think this offered me a lot of opportunities. So my point being is that even if you're late to the game, you can be successful with your career in medicine. And so how did I get here? Again, I didn't have perfect grades, but I worked really hard. Actually got a C in college, and I still became a doctor. So I went to medical school in Fort Worth in Texas, and then this is a picture of me in medical school. This is my match day when I matched to residency at Texas Children's Hospital. As you can see, I was very excited. So I did my residency at Texas Children's Hospital in Houston, and then I did my fellowship in Austin at Dell Children's Medical Center. And this is the day I matched to my fellowship. And then this is the day I graduated fellowship. And now I am a supervising doctor and attending doctor. So these are all the tests I took to become a doctor. I took 3 different tests, or actually 4 different tests, because I went to an osteopathic school. So I took 4 different osteopathic medical school tests and board exams. And I took the allopathic tests, which are all the tests that the medical non-osteopathic allopathic medical school students take. And I took the general pediatrics exam, and I'm taking the pediatric emergency medicine board exam. So it's a lot of tests to get me to this spot, but it's exciting because it's worth it in the end. What did all of this work, all of this long time get me? What this got me was happiness and a lot of fulfillment. I truly have the best job. I love my job. Every day is exciting, and I'm never sad to go to work. And I really feel like I have a chance to make a difference. So every single day, I'm changing someone's life, whether it's comforting families or making a kid safe when they're sick. I have a lot of flexibility as an ER doctor in my work-life balance. And I get to learn forever. Every single day, I learn new things, or multiple new things every single day, interact with lots of different people from all different walks of life. And I have a lot of personal growth. So every single day, I learn more about myself and learn more about how I interact with others and learn more medicine. So I continue to grow. And of course, financial security. So again, I'm always going to be able to find a job, and I'm always going to be able to have money to protect my family. And this is a picture of the house I live in, which is what I got with this job. So it's nice and peaceful and quiet. So what do I actually do in my job? Aside from how I got here, I want to talk to you guys all about what I actually do. So what I do, I comfort scared parents. A lot of the time in the ER, a lot of our patients aren't super, super sick, and it's more that their parents have a lot of questions and they want to just make sure that their kiddo is okay. So I get to comfort scared parents. I get to diagnose illnesses. People come in with medical mysteries every single day, and I get to kind of play detective, and that's really fun. It keeps my job exciting. And I really get to play. I get to play all day. I get to play with toys. I play with the kids with the toys. We get to do Play-Doh, and it's super fun. There's nothing better than having a kiddo that you're taking care of, who's your patient, who's smiling and laughing with you. And I work as a teammate. So I help the nurses when they need help, and the nurses help me a lot. But we all work together to make sure that we're taking good care of our patients and each other. And most importantly, I lead the team. So anytime there's a patient in the ER, I'm ultimately, when they're my patients, I'm the team leader. And so I'm the one who has to make those last minute decisions to make sure that they're safe. And then of course, I save the lives of kids when they're really, really sick and they're not doing well. I'm the one who saves their life with my team. So it's awesome. It's a great job. And sometimes I get to ride in helicopters, which is pretty cool. So what is my schedule actually like? So my schedule where I work 13 8-hour shifts, and these are the shift times. So the shifts are 8 hours, so 7 a.m. to 3 p.m., 9 a.m. to 5, et cetera, et cetera. And then this is actually my schedule for the month. So I work 4 7 a.m. shifts this month and 1 9 a.m. shift. And then I have 2 backup call shifts, which means if another supervising doctor is sick, or they have a family emergency or something where they cannot come into their shift, then I'm on call for that day, so I can come in and work if I need to for them. So what are the other things I've done besides work? So my job is awesome because I'm an ER doctor. I work a shift and then I'm done for the day. And so because of this, I've gotten to do 6 days on vacation with my friend. I have submitted a research abstract. I have done 2 medical student orientation days, 2 medical student feedback sessions. I have a simulation day, which I get to spend the day teaching our emergency medical services, like our paramedics and people that are in the ambulances and stuff, how to take care of kids when they're out in the field, and we get to practice that and learn all these cool techniques. And I have 4 meetings. Some are related to research and some are related to the medical student clerkship that I'm the co-director of. And then I'm giving 1 presentation today, and I'm attending a birthday party. And then I have 3 social events with friends. And my dogs have 2 vet appointments. They're okay. Don't worry. It's just checkups. And then I myself have 1 doctor's appointment. So lots of time to do other things. These are kind of other examples of things I do when I'm not at work, presenting my research at international or local conferences, or writing papers and getting these things published to help, educate people on how to take care of kids that are really, really sick. So what are the perks of my job? So the perks of being a pediatric emergency medicine doctor, aside from the work-life balance and all the other stuff I just talked about, are that you have a pretty good salary. The average range for a fresh out of training doctor is around $230,000 to $250,000 a year. Plus you can get some extra money if you work extra shifts, which is called moonlighting, and you can get additional money for if you're doing research or having like a teaching position. Most places will give you free healthcare insurance, vision insurance, dental. You get a retirement plan, and your employer usually contributes some extra funds to that. And then you get extra money to do other things. So like go to conferences or do, buy tools you need to do your job well. And then most places will pay for your licensing and extra board exams and tests like that, which is really cool. And my particular job gives you free covered parking, which is a big perk. So this is another example of photos of what I did at a research conference. So I went and presented at a conference and got to work with a ton of other doctors. And when we were done for the day, we all went to Niagara Falls. So lots of work-life balance. So who else do I work with besides other doctors? I work with physician assistants and nurse practitioners. I work with residents who are people who have graduated medical school. So they're doctors and they're learning how to practice medicine. I work with a lot of doctors in family medicine residencies and emergency medicine residencies, of course, the pediatric residents, and then our fellows, who you met 2 of my fellows last week. Most of them are board certified pediatricians who are now doing extra training in pediatric ER, but sometimes we have emergency medicine residents who have graduated and are emergency medicine doctors who are learning how to do pediatrics. I work with medical students, nurses, respiratory therapists, EMTs, paramedics, all the people that come and bring our patients to us. I work with social workers. We have techs, both in the ER and the people who take our x-rays. Environmental services, our cleaning staff, and they keep our patients safe by making sure they have clean rooms. Our volunteers, security, and police. So I work with a lot of people, and I get a really cool job. Again, I get to interact with all these people from everywhere every day. This is a picture of part of my team at my last place I worked, and this is what the ER kind of rooms look like when you're having resuscitation. And as you can see, we're all very happy. There's some doctors and nurses and techs in here, and we all love our jobs. It's me working with our ambulance crew and with, again, I'm a mentor, but this is my mentor. This is kind of my everyday day-to-day life and the people who I interact with. So what actually is my life like? So this is my exact schedule for the next 2 weeks of my life. So as you can see, I have 4 shifts this week, and all of them happen to be at 7 a.m. I have a student feedback session. I am on a committee where we do debriefing of how we talk about ways we can make our patients safe after they've had a critical illness, and how our teams can work together to make things happen quickly and safely for our patients. Today I had a nursing provider breakfast, which was pretty cool because we get to interact with your nurses and get to eat some hospital provided food, which is pretty nice. And then we had a business meeting. I'm doing a presentation, and then I submitted an abstract that was due tomorrow. And then this weekend, Sunday, I'm going to a ladies' lunch. Next week, as you can see, my schedule's pretty low key. I really have 1 shift. And the rest of the things I'm doing are kind of more my passions, which are research and working with the medical students, doing a simulation day where we do that practice session and teach our EMS community on how to keep kids safe out in the field when they're not at the hospital. And then I'm going to my run club this weekend and going to a birthday dinner. So it looks like I have a totally empty schedule next week, which in reality I do. And I have all this free time to do whatever I like. And usually I spend that by studying for my boards or, catching up on other social events with friends and family or doing research. And then what is an actual day in my life? So I'm going to talk for the majority of the rest of the presentation about what an actual day in my life is and what it is actually like to be an ER doctor. So most of the time, even on days off, I get up sometime around 6:30. And I wake up, I make breakfast, I drink coffee, play with my dogs. And this is a day when I have a 3 p.m. shift. So my shift is 3 p.m. to 11 p.m. And then after I make breakfast, I study, I work on projects. And then if I have any charts left over, like patient charts that I have to do from the day before to make sure that all their information is safely documented, I finish those. I exercise in my home gym, which is super important. It's hard to find the time to do that in our daily lives, but it's really important to make sure that your heart is staying healthy and that you're able to take care of yourself so you can take really good care of your patients. After that, I play with my dogs, we go on walks, and then I get ready for my shift. 12:30 to 1:30, usually I make lunch and I prep something to take to work for dinner. And then I catch up with other stuff, whether it's watching a Netflix show or I can, pay bills or, who cares? Read a book, anything. I have a little bit of extra time that I allow myself every day. And then I leave for work and I usually pick up Starbucks on the way that I order ahead of time because I'm an ER doctor and we're always super energetic and gotta keep our caffeine. And then while I'm driving to work, I usually listen to an audiobook or a podcast, or sometimes I'll catch up on a call with the families. And then I work my shift from 3 to 11. So what is an emergency department like? Every emergency department is different. My emergency department has 5 zones, and there is a supervising doctor in each zone. Plus, usually there are residents and physician assistants. Sometimes there are fellows. And then our zone, our hospital also has a full zone that is really cool. And it's kind of like the urgent care. So where the kids who are like a little sick but don't need any life-threatening and life-saving interventions go. So our general pediatricians go there and they work and they're the supervising doctors over there. And our physician assistants and nurse practitioners work in that zone. So who are the patients? Who are the patients I take care of? I take care of kids from newborn, day of life 1, 4 hours old sometimes, to 18 years old. And sometimes even an adult will pop by because they're not sure that we're a children's hospital. And sometimes I take care of them when they're sick and they need to be stabilized. Some of our patients are older patients who are in their 20s or 30s who have long-term medical conditions, and they see their main doctors are at the children's hospital because they have illnesses from being a child. And so I take care of them when they come into the ER and they need help. A lot of my patients are pretty healthy. They're just there because they have a rash that's not a scary rash, or they're there just kind of for a checkup because their parents have something that they're worried about. Some of my patients are really, really sad and thinking about hurting themselves or other people, and I take care of them too. And then, of course, I take care of sick patients who have appendicitis or infections, and then the critically ill patients, the patients who need life-saving intervention right now. I prescribe medications for people to go home with. I give medications when people are in the ER. I order life-saving treatments and respond to emergencies, which is, again, the biggest part of my job. The rarest things that we see are the big, big emergencies, but when they happen, we got to be ready. And of course, I get to solve mysteries. Sometimes I just do checkups. Okay, so I want to give you all a warning. The rest of this talk, we're going to actually go through moment by moment the patients I see in a day, because I want you all to really get a good understanding of what it is actually like to be a pediatric ER doctor. And so we're going to talk about all the patients I see and how busy we get, and there's going to be some sick patients we're going to talk about. So I just wanted to give you all a warning. These patients are all made up, but they're examples of patients that I've taken care of pretty much regularly every day. So we're going to walk through my day. So when I get to work after, I've gotten my Starbucks, At 3 p.m., I walk in the door, I say hello to the nurses, the flow supervisor, respiratory therapist, and then I log into my computer because it takes a long time for the computer to log into a new person. I log into my phone because I have a phone app where I have to log in so everyone knows that they can reach me. I put my lunch away and then I introduce myself to the residents and I say hi to all the other colleagues, the other doctors, the physician assistants, nurse practitioners, anybody else that's sitting in the provider box. And then I get sign out from my 7 a.m. colleagues so that they can go home. And it's really important for me to get sign out so that they can leave and finish their day and go home to their families or do whatever activities they want. But we also want to be very conscientious about making sure we're doing a very appropriate and timely sign out so that all our patients can be safe. And if they need any interventions that haven't been completed, that I can take over their care. So we're going to talk about one of my usual days. So I get sign out from my colleague at 7 who was there all day from 7 a.m. to 3 p.m. and I'm going to be there till 11 or so. She has 3 patients that are still in the ER that are getting workup still, and she wants to tell me about them. There are 2 patients that haven't been seen yet, and I know I'm going to have to see these patients that are still on the board. One is a 7-month-old with a fever, and one's a 2-year-old with an arm deformity. So we think they probably have a broken arm. And they're both level 2s, which means they need to be seen within 15 minutes or so of the time that they arrive. And there are 3 patients that the residents have seen, and the residents need to tell me about them so that we can start doing their workup and making sure that they're okay. So these are the patients I get for sign out. An 11-year-old who broke his arm. He had a ketamine sedation, so he was put to sleep with an IV medicine, and now his bone was put back by the bone doctors, and now he's waking up. So he has to wake up all the way and then be able to drink, and then he has to be able to walk on his own to show us that he's fully awake from his medication so that he can go home. So my job is to make sure that he's okay and stable for discharge. I have a 2-year-old that's having an asthma attack that's getting their first hour of their breathing treatment. And so my job is to reassess them at 3:25 and then decide if they need more treatments or if they're getting better, if they're getting worse, if they can go home, if they need to be admitted to the hospital, or if they need to go to the ICU. And then there's a 17-day-old with a fever who just had labs all done through the IV. So they got an IV and they got a spinal tap because they're only 17 days old and they could have a serious life-threatening infection of the fluid around their brain. So this baby is getting IV antibiotics, but I have to wait for the results of the spinal tap or lumbar puncture, which is what LP stands for, to decide if they're stable to go to the floor or if they have to go to the main hospital floor or if they have to go to the ICU. So I have the 3 resident patients to hear about, and there's, remember, 2 other patients that haven't even been seen at all by a doctor or a physician assistant. So there's a 14-year-old girl with 1 day of abdominal pain, vomiting, and chills. She needs an appendicitis workup and an ovarian torsion workup because the resident thinks that their belly is really tender and something is going on and they might need surgery. There's a 17-month-old boy who jumped off the couch and cut his lip open, and he needs stitches. So he has a big laceration. And so I asked the nurse while I'm sitting in the doc box, can you please apply the numbing medicine, which is called Lent? And then I have a 7-month-old girl who is vomiting and she's lethargic. So she is pretty sick and the parents are worried and the resident is worried about her. They think she probably has intussusception, which is a bowel blockage. So my plan is I got to go see this baby because the 7-month-old looks pretty sick. And then we got to start the workups on the other 2, on the other girl with the belly pain. Before I get to see them, I hear overhead, medical response, room 15, and my phone alerts that this is a medical response, which means this is a sick patient who needs treatment immediately or they're going to die. So who is the medical response? The medical response, I walk in the room. All I know about this patient is that they're a 9-year-old who suddenly has altered mental status. So they're not acting right and their parents are worried. This kiddo has been vomiting for 2 days and just had a fever one time 3 days ago. And when this kiddo checked in, they looked pale and very, very weak in triage. So our nurses up in the front in triage checked a blood sugar and their blood sugar was over 600. So that tells me right away that this kid is likely having a diabetic crisis. And I don't know why, but my job is to help figure it out. But most importantly, I have to stabilize this patient. So my role in this room is to lead the team because I have awesome nurses and respiratory therapists who can do the hands-on stuff to actually take care of the patient. And I have residents with me and physician assistants and fellows who can actually do the assessments and look and listen and make sure there's nothing that we're missing. So my job is to be the communicator. So I communicate that we rapidly need to initiate stabilization. So we need to place this kid on oxygen to make sure that he's getting enough oxygen to his organs. We need to give IV fluids. So we need to stop this blood sugar from getting higher. We need to give this kiddo nausea medicine so that they don't keep vomiting and get more and more dehydrated. And this kiddo definitely needs insulin to treat this high blood sugar from their diabetic crisis. So we get all these things done. My awesome team is so fast. And this only takes us 37 minutes to stabilize this child and get this kid admitted to the PICU. So the PICU doctors come down and they say, we're going to take over care. And so I transition care to the PICU. They're going to take this kid to the CAT scanner to make sure their brain's okay. Because we want to make sure that they're not missing anything, that they don't have brain bleeding or a brain tumor or something that's made them suddenly become altered. So now that that patient is stable and safe, I got to get back to the other kids. Luckily, while I was in that room, the PA, our physician assistant, saw the child with the fever that's a level 2. And so they're starting the evaluation on that kiddo. The fellow is going to go see the patient with the arm deformity. So now I got to go see the other resident patients. So I got to catch up. I'm getting busy. So I got to follow up on my sign out from my previous attending and still see the patients from the residents. So first thing I'm going to do that's quick and easy is follow the labs on the newborn. So I'm going to check this baby's labs and see if they can get admitted. And it looks like they don't have meningitis. So I'm going to send this kid to the regular hospital floor. My resident is going to call the hospital medicine team and take care of all the things to get this kid admitted. So I can check this kiddo off my list. Next, I want to see if this kid with ketamine that got put to sleep and his arm got put back in place is awake and drinking, because I want to see if he can go home, because he doesn't need to sit around in the ER for longer if he's feeling better. And I go by the room and check in, ask the nurse, he can go home. So that's awesome. And that opens up another room for a sick patient that's in the waiting room. So I know I have to see this infant with the vomiting and the lethargy, because this kid is the most sick of the patients I have left to see. And luckily the resident has already ordered the ultrasound, which has been completed. And I look at the ultrasound and I can see, because I'm an ER doctor and I've reviewed many ultrasounds, that this kid has a target sign. So that means that this kid has a bowel blockage. This kid is gonna need to get this bowel blockage fixed. So I know this kid is gonna have to be taken care of by the surgical specialists. So I call the surgeons before I go see the kid, and I ask them to review the chart and take a look at the ultrasound so that they can get this kid ready to get better. If I leave this bowel blocked for too long, the baby's bowel can die and they can get really sick. So I'm going to go see the patient while the surgeons are reviewing his chart. And then the teenager with the abdominal pain, her ultrasounds are all normal, and the resident says that the kid has taken fluids and she's feeling better after she got some nausea medicine. So I'm going to get ready to go see if I can discharge her so that she can go home and doesn't have to sit in the ER. Uh-oh, I hear a beep, 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 which means an ambulance call is coming in on the phone. And I know there are still 2 patients to be seen that haven't been seen by anyone. And I hear from the doc box, this is Medic 6 calling about a patient with CPR in progress. How do you copy? And I hear it from afar. And so overhead, I hear, we need an attending to the bat phone. And it's kind of cool. They call the bat phone. So that means they come in on the phone, and I come in and answer the phone. It's bat phone, fun. So I go to the bat phone and I say, Doc, 1, 2, 3, 4, go ahead, I'm listening. And I hear back from the ambulance team. Hi, Nemours, I'm 10 minutes out with CPR in progress. I have a 14-month-old girl who was found down in the pool. The neighbor's a nurse, and they administered rescue breaths and started CPR. We have an unknown downtime. We think it's 15 minutes, and we're on our 3rd round of CPR. She's received 2 doses of epi. She's getting bagged. We couldn't get an airway. Her D-stick is 245. We don't have a blood pressure. Her temperature is 35.1. Her ETA is 10 minutes. Any other questions? And I reply, I say, no questions, call back with any updates or changes. So I'm getting worried. I'm getting nervous. I know I got to get my team in line so we can try to save this kiddo's life. So I asked them to page overhead, medical code, ETA 10 minutes. So 10 minutes, this kid's coming, and we need to notify the whole ER so that we can have as many people ready. So we gather the team, and luckily, on this shift, I have a fellow, which is cool because the fellow can help do the primary assessment and make sure that the kid has an airway, like a breathing tube, to make sure that we're ventilating. And I have respiratory therapist who is also going to help make sure that kiddo has a great airway. We have 3 nurses. Those nurses are going to be able to get quick IVs, and they're going to be able to start giving medicines and fluids for this kiddo. And then I know we need at least 2 people to do CPR, to do those chest compressions to keep that kid's heart pumping so we can keep the blood flow going to their brain and their organs. And then I also need people to help make sure that we can get the kid on the monitors so I can see the kid's heart rate and I can see the kid's pulse oximeter and make sure they're breathing. And then I have a resident and a PA or a PA with me who's awesome. So they can also help me with the assessment of the patient and see how the patient is doing and responding to our interventions. And they can also help enter all the orders of the things we need in the computer. And then do I call anesthesia? We are super lucky where we have anesthesiologists who are special doctors who can manage difficult airways. And so we call anesthesia so that they can come and assist if we need assist. But luckily, there's another ER attending who's also free, so they can come in and help the fellow with the airway. So what is my role? So I gather the team, everyone's in the room, and I give a brief recap to the team. So I say, all right, everybody, let's keep it quiet. Let's update on what's happening. So we have a 14-month-old child who is drowned. They're getting CPR. They do not have an airway in place, so we're going to need to put in an airway. Their blood sugar is 245. We do not have a blood pressure, and their temperature is 35 degrees. So I tell the team after that, the plan. I say, I want these labs and I want these medicines and these doses ready. And I would like these airway supplies ready because our priority is continuing high quality CPR, chest compressions, and making sure this baby can breathe. Okay. Does anybody have any questions? No questions. Then we're going to prepare the room. We get the backboard ready and the step stool ready so that we can get ready to provide high quality CPR, which is the most important way that we can save this baby's life. And I look at my watch and I have 6 minutes before this kid arrives. So I'm going to run to the bathroom and I'm going to eat a power bar because I want my brain to be working as best as it can so I can try to help my team save this kid's life. So my patient arrives. So this patient arrives, and the first thing we're going to do is we hear a 30-second report from the ambulance team, and we're going to continue CPR according to our algorithm for pediatric advanced life support, which means high quality chest compressions and making sure that we are breathing for this kiddo. So the fellow and the other attending with the anesthesiologist are going to put in the breathing tube, and they do that successfully. So they get the breathing tube in and we're able to breathe for this baby while we're continuing high quality chest compressions. While all these things are happening, everything that runs through my mind as the team leader is that we got to continue CPR and it's got to be high quality because that's the one thing that's going to make a huge difference. And then could this child have a pneumothorax from all this extra pressure we're pumping into their lungs, which is a lung collapse, which would also be a big emergency. And that would need a whole new procedure to treat this. Does this kid have any other trauma? Did they fall and hit their head on the side of the pool? Do they have any brain bleeding? Do they have a neck injury that we need to stabilize? I have to think about these things and make sure that if we're able to save this kid's life, that we're also giving them good quality of life when they wake up. And then I also have to ultrasound the heart, and I want to make sure that the heart is still working in between our CPR compressions to see if this kiddo has a chance to survive. And then I want to make sure we're giving epinephrine every 3 to 4 minutes, which is adrenaline. And that's going to help that heart keep pumping and keep their blood pressure up to make sure all their organs are being saved. And then how are we going to continue to ventilate this patient? Are we going to breathe with the bag and squeeze the bag? Or are we going to put them on the ventilator? And then last, does this child need ECMO, which is a special other type of life-saving treatment that requires a surgical procedure? And do I activate the ECMO team and call them in? All these things run through your mind as the team leader, and there's a lot going on, and sometimes it seems kind of chaotic, but there's a method to the madness, and all of this is with the goal of getting this kid's heart rate back so that we can provide them a good quality of life. And what happens next with this kiddo? Luckily, we get ROSC, which is a big hurrah. That means we get return of spontaneous circulation. So this kiddo's heartbeat comes back on its own after we've done the chest compressions and after EMS has started that awesome CPR in the field. We admit this child to the pediatric ICU, so they're transported successfully, and I hand over my care to the team leader of the pediatric ICU, who's the ICU doctor, and you're gonna meet one, I think, in a couple weeks. And so now, after this has happened, despite this huge event that's happened, the team has to go back to the ER because we have a ton of other patients to see. And it's only 6:15, so it's only been 3 hours since I started my shift. And I have 3 new patients to see by now that the resident and PA saw, plus all the previous patients that I saw and got signed out on. So what do? I feel like, oh, there's a lot going on, but I still got to keep things flowing because we could get another sick patient, or one of these patients I had could be really, really sick. So I got to follow up on everything that's going on. So the kiddo who was originally assigned out that has asthma, I check in on him. That kiddo needs more albuterol, which means they have to go to the hospital. So I call the hospital medicine team and they get admitted. The fellow and I go put the kiddo with the broken arm to sleep so that the orthopedic surgeons, the bone doctors, can put the bone back. So now we got to make sure he wakes up safely from his procedure and that he can drink and walk and go home. The kiddo that had the UTI, the baby, luckily they look super well and nothing else is going on. And we know why they have a fever, so they can go home with antibiotics. My intussusception, the bowel blockage patient, is getting their procedure by surgery. Surgery is fixing it right now, and I know they're going to come back to the ER, so I have to check on them when they get back. And then the teenager with the belly pain and the normal ultrasounds gets to go home. I check on her, she's doing well. And I remember I still have to go see the toddler that has the lip cut because the resident wants to do the stitches, but they've never done any before. So I have to go in there and supervise the resident. And then I hear, before I go see these other patients, about 3 new patients from the residents and the physician assistant. One is a 3-year-old with belly pain, fever, and headache. And the resident tells me that this kiddo actually looks really, really well. I don't think it's anything serious. This kid has strep. It's positive test. He can go home with antibiotics, but I still have to see him, make sure there's nothing else that's going on, nothing that we're missing, so that when this kiddo goes home, that they go home and they're safe. I hear about a 16-year-old who has a history of a big heart surgery who's here with chest pain. So this patient makes me nervous. A kiddo that has a history of a big heart surgery that's here with chest pain. I know I'm going to have to see this patient and start their workup and evaluation before I go and do the stitches on the kid with the leg. And I have a 14-month-old who has increased workup breathing. So they're breathing hard, they're breathing fast, and they have a fever. They probably have bronchiolitis, but they could have a pneumonia or something else going on that could need treatment. The resident has already given them some Tylenol to help with their fever, and the resident has ordered suction to see if we can get that mucus out of their nose to help clear up their breathing and make it easier for them to breathe. And they're going to try a breathing treatment and see if it helps. And this baby, I can kind of walk by and do a quick assessment and decide if I need to go in and do some other treatments, or if I can wait to reassess them and get a full history after they get their initial treatments. So triage is like basically a system of who do I see first? How do I get things flowing? And how do I make sure I'm keeping all these patients safe? So triage is, I want to see the really sick kids and I want to see the kids who can go home so that we can make them safe by not having them stay in the ER around other kids that are sick. And I'm sure no family wants to sit in the ER, and make room for other patients to come into the room that could be sick. So I triaged. This is how I triage these patients. I see the child with the strep because I want to make sure they look good, but I know why they have the belly pain and the headache and the fever, and I think they can leave. And so that whole visit takes me personally 12 minutes. And then I pop by the kiddo with the chest pain, do a quick exam, make sure there's nothing that's life-threatening that needs emergency intervention from me. And this takes me 7 minutes, but I know I'm going to be back because I have to do a more detailed assessment on this kiddo later. So I eyeball the little 14-month-old with the hard breathing from the door, look to see how this kiddo looks. And this kiddo actually looks okay. He doesn't need any extra oxygen or anything. So I'm going to come back in a little bit and do a full head-to-toe exam and get the whole story and make sure that this kiddo doesn't have an ear infection or anything that needs antibiotics. So right now, I got to grab the resident because this kiddo who has the cut on their lip has been here for too long, and we got to get this kiddo's lip fixed so that they can go home. So the resident comes with me, the resident does the stitches, and I stand there and assist and help teach them while they're doing the stitches. And this takes 21 minutes. And if I had been by myself, it probably would have taken me less than 5. But I know it's important for the residents who are learning how to be doctors to learn how to do this, and especially on kids. So I'm patient while they do the laceration repair, and this kiddo gets to go home. So I go back, I check on the kiddo with the chest pain, and all their labs and imaging is done. So I can review all of this, and I ask the resident to page the cardiologist, the heart specialist. All of this looks good. Cardiologists are going to call us back. And I take a moment for myself where I drink water and I go to the bathroom. And I come back to my desk and I eat a cheese stick, nuts, and an apple while I'm dictating a note, which means I'm talking into my phone and my phone is recording on the screen what I'm saying so that I can try to document some information about the patients that I'm seeing. It's a crazy day, very busy. All right, so what are my next steps? I go back to the 14-month-old that was having the hard breathing. This kiddo looks really good. This kiddo is taking oral intake, he's smiling at me, he's laughing. Talk to mom and dad. They feel comfortable with going home, and I think this kiddo can go home. And I talk to them about what to watch for, what to look for when they need to come back if this kiddo is getting sick. All right, I have 3 more new patients to hear about from the residents and the physician assistants. So one of these kiddos has a big scrape on their forehead after a fall. The resident thinks that this kid can go home and this kid is doing okay. The other baby that I hear about is a 3-week-old who has a big red toe. And the resident tells me that they think this is a hair tourniquet. So it's a piece of hair that's stuck, wrapped around this little tiny 3-week-old's toe. And they couldn't get it off with some forceps or tweezers. And so I go in and apply Nair, the hair removal cream, because I can't get this off either without hurting the kiddo. So we need to make sure we check back in 10 minutes and don't leave this Nair on too long to burn the kiddo's skin. And we really hope that the Nair helps dissolve the hair, because if it doesn't, then we're going to have to actually make a big cut on this little baby's toe to get this off, which is going to hurt. And we don't want to do that if we don't have to. And then I hear about a kid who's 5 years old who has autism and he's drooling. This kid is drooling and looks kind of sick. This kid's an ESI 2, which means this kid was seen by our triage nurses who are very experienced up front, and they thought that this kiddo was really sick and needs to be seen by a doctor within 15 minutes or they're not going to be okay. And the resident saw this kid and thinks that they have a big throat infection and they're pretty sick. So what do I do next? How do I see all these patients while keeping track of my other patients? My priority for triage, I eyeball the kiddo with the autism who's drooling, because I know this kid is probably sick and I need to decide if they need more treatments right away. So I do a quick heart and lung exam, look at the kiddo, and I agree, this kid is sick, they're drooling. I'm going to get a chest and abdominal x-ray and we're going to do some labs because we don't know why he's drooling. I have to keep a close eye on him, so I'm going to be back soon. I see the kiddo with the forehead scrape and he can go home. He looks really good. He doesn't have a head injury otherwise. He doesn't have a neck injury, running around and playing. He's already had some apple juice. So I totally agree with the resident. This was a great case. This kiddo is ready to go. The kiddo that the broken bone that the fellow and I put to sleep has already woken up. He's drinking. The orthopedic bone surgeons have already talked to them about what to do with the cast, and this kiddo can go home. So we discharge this patient. And then the resident and I check back in on the kiddo with the hair tourniquet, and the resident's able to get the rest of the tourniquet off because the Nair worked. So this 3-week-old baby's toe is already looking better. There's better blood flow. It's nice and pink. I'm so excited. The family is so happy, and this baby gets to go home without a big procedure to cut their toe. All right, guys, it's 9:55. Who's left? I got to take care of all the rest of these patients and still make sure that in the next hour and 5 minutes of my shift that I'm taking care of everybody. So the patient with the drooling, I check back in and I look at the pictures, and on the pictures I see there's a big battery, a big circular battery in this kid's esophagus. So the tube that goes from his mouth down to his stomach, there's a big battery in there, and this battery is likely eroding the esophageal tissue. So this is an emergency. I know this kid has to go to the operating room to get this taken out, or he could get a big hole in his esophagus that could completely affect the rest of his life. So I call the GI team and I put in the orders quickly for this kid to go to the operating room. I touch base, cardiology has called my resident back, and cardiology says the kid with the heart disease, everything looks great. The labs look great. We think it's probably a muscle strain, which is what kind of we thought too. He got some pain medicine, feels better. He can go home and follow up with them in their clinic. And I just heard that the kiddo with the bowel blockage is heading back from the operating room. So on the way back from surgery, they were able to put it back and fix it. And so I have to make sure that this kiddo is stable to be discharged, which means they have to be able to drink without throwing up, and they have to be well appearing and kind of back to their normal self. And there are still 4 patients in the ER that need to be seen by an attending. So we need to see these 4 patients. It looks like 1 patient is really, really sick. So maybe I can see them before my time is up at 11, because it's really important that an attending goes and sees this sick baby. This baby is a newborn. This baby was born at home 2 days ago. This baby has not been seen by a doctor yet in their little life. This baby is having a lot of redness at their belly button where their umbilical cord stump is. And I think that this baby probably has omphalitis, which is a big infection of that skin and that belly button, which is a life-threatening emergency in a newborn. So I know I have to go see this kiddo, or they could get really, really sick and potentially die. And I'm excited because another attending physician, another supervising doctor, is coming at 10 o'clock. So they can see all the new patients who come in while I wrap up over the next hour. So what do? This is in power hour. So my power hour is basically my last hour of my shift. And where I work, in our last hour, we don't see very many new patients in our last hour. Our last hour is really for tying up, patients, calling our consultants, making sure if there's anything else that needs to be done before we go home, that we can do everything we can to make the next attending's life a little bit easier and make sure our patients are safe. Other jobs, sometimes you don't get that extra hour with that overlap where you still see a lot of new patients in the last hour, and that just kind of depends on where you work. So I have a power hour. So my last hour, I'm going to tie up all of these patients I have, and then I'm still going to try to see some new patients if I have time and my other patients are stable. But I know they have to be pretty quick. Ideally, they're patients that I can see and that I can get them home and that don't need a whole big workup for my colleague to have to take over all this care. And I try to work on some notes using my dictation on my phone, just so I can have some documentation of all these patients I've seen. And then I see 1 patient, and this patient has a cold actually, so it was a good guess based on their complaint of why they were here. And this kiddo gets to go home. So that kiddo goes home, and now there's space for another patient that's in the waiting room to come in and be seen. So at 11 p.m., there's another attending who comes on. So from 10 to 11, the 10 o'clock attending is now seeing all those really, really sick patients. Anybody who needs a lot of workup or a lot of treatment, that 10 o'clock attending is going to see them because they're going to have a lot of time to be able to take care of them. So the second new attending for overnight comes in at 11 o'clock. So at 11 p.m., I get to tell them about all the patients I have left to make sure that my patients are safe and that they can follow up and make sure that they're taken care of. So I talked to them about the baby with the omphalitis who has labs pending. So this baby's workup has been started. This baby needs to be reassessed, and then they need to be admitted. I've already started antibiotics, but this baby needs to stay in the hospital. They're not allowed to go home because they're too little and too high risk. My patient with the bowel blockage, the intussusception, hasn't been able to drink yet, but they look okay. So we're just waiting for them to feel a little more comfortable after their procedure so that they can drink and go home. So I need this attending to go check and make sure that this baby has drank and continues to look well, and then they can be discharged. And then I tell them, FYI, we just got an ambulance call. There's a medical response who's coming in 12 minutes. So this is a 2-year-old who's having a big febrile seizure, and they're still having seizure. So you're going to have to address that in the trauma bay when they arrive. And all my patients are signed out. I feel like they're safe. So I get to log out of my phone, I log out of my computer, and then I leave and drive home. And on the way home, I usually listen to an audiobook because it keeps me, kind of lets me decompress. And also, it's 11 o'clock at night. Sometimes we get tired and you want to do things that keep stimulating your brain so that you're safe. I get home and I have frozen enchiladas. So that's what I eat for dinner. Because unfortunately, I did not have time to eat my dinner on shift because we had those 2 really, really sick patients with the medical response and the medical code. And so I eat my enchiladas at home, which was awesome and tastes delicious. And then I watch 2 episodes of a show on Netflix before I go to sleep while drinking lots of water to catch up from the water I missed throughout the day. And I go to bed. And that's the end of my day. So in wrap up, long story short, generally short, my job is really fast paced. It requires full attention 100% of the time because people's lives are at stake. And even the kids who don't come in that look like an emergency. Some kids come in and they look pretty well, but they could have some serious problems. And so I have to be full 100% attention all the time and thinking about all the things that could happen to them if they go home. And so I have to make sure that I'm not missing anything scary or dangerous. And it's great because I get to use my brain and use all that knowledge that I learned growing all through med school, all the way through fellowship. I work with people from all over. I see patients from all over. I meet families from all over. I get to pursue passions I'm interested in, like research in child abuse, pain management, patient safety, and then doing medical education, teaching the medical students, helping with their clerkship, teaching the residents and the fellows that I work with, and then doing simulation for our community, our EMS teams, our fellows, our residents, other supervising doctors, nurses, respiratory therapists. So I get to do all these fun things that are not taking care of patients that I love, that bring me joy. And generally, I have a nice work-life balance. When I'm at work, my life can be really crazy, but when I'm not at work, I get to do a lot of the things I enjoy. I get to, go to dinner with my family. I get to do all these other interests. I get to do the research I like. I get to go on vacations. And with my job, it's very stable. I can afford to do and buy the things that are important to me. My job's not easy. I love it. I think I have the best job in the world. I wouldn't trade it for anything. But most importantly, when you're picking a career, I want you to pick a career where even on the most boring day, when you're just seeing the coughs and the colds, you're still really happy and you're really excited to go to work every single day. This is part of my work-life balance. This year, one of the many trips I've been able to go on because of my schedule, I went on a safari, and these are some pictures I took with my own cell phone. Pretty cool, huh? And these are a picture of us on the safari and on another trip that we went on in Nashville, just two of our many trips we've gotten to take this year. So in summary, think about it. It's the best career, best job, super fun. Every day is a new day. Every day is a happy day. That's it.
Wow.
Wow is right.
I
That was overwhelming.
texted Christy and I told her that I would have chronic high blood pressure and panic attacks, but
We train for it. It's awesome. It's truly, for me, it's the best job. You have to know yourself. There's a lot of awesome jobs in healthcare, like nurses, respiratory therapists, paramedics, our EMTs. Like there's so many cool jobs, and this is just the right job for me,
right. So let me ask you a question along those lines. When you were in 5th, 6th, 7th grade, did you envision this for yourself? And did you have this level of energy back then that just wasn't channeled yet?
It's a good question. So, I think I always knew I was going to work with kids, and I had an idea that I wanted to do pediatrics just based on growing up with my mom, my life experience. I actually did not like emergency medicine in medical school at all. On my emergency medicine rotations, I did not enjoy them. I did not find them fun. But then in residency, I had a great fellow that I worked with a lot, and she got me really motivated and excited for these really interesting cases and did a lot of teaching and totally, completely changed my life path. So I think I always knew I wanted to do medicine because I just found it so interesting and fascinating. I've always had this much energy. I used to have more, actually. So I think it's the perfect career for me, but I didn't always know I was going to be an ER doctor. And, I always thought I would actually end up like doing pediatrics working in a clinic because I love taking care of kids and like getting to know their families and seeing how they're doing and watching them grow. But this actually kind of worked because I get the best of both worlds. I see some kids more than once a week. Like I just happen to see them when they come back to the ER. And so that's kind of fun too. But I get a combo of really sick and really healthy, and I get to play, so.
Right. And I want you to know that those hearts and bugles and stuff that have been going up the screen, this is the first time ever that has happened.
Oh, thanks guys. You're so sweet. I feel like I was a little nervous to tell you all about what it's actually really like, but I feel like you don't get to know that. And I want everyone to make a really informed decision with their life. And it's okay to change your mind. Again, like I had a whole job before I became a doctor. But I think it's important to like know what we actually do and what's actually happened. So I appreciate that. Thank you all. You're so sweet.
All right, so to the official questions. So, Dr. Sanchez, you can also open up the Q&A box at the bottom of your screen,
Oh, I see.
and you can see the Q&A. We've handled some of the more mundane ones, but let's just start right at the top with Uttam.
Yeah. Where did I take my extra year of classes? So I actually just enrolled. I actually took them at UT San Antonio. I actually did I was living in San Antonio, Texas at the time. Long story short, but it was for my husband. We met in California and ended up moving to San Antonio. And we were living in San Antonio while I was working, and I just was like, it's time to go back to school. And I just applied to my local state school just because I knew I had to take these prerequisites. So I did them there. I didn't do there are a lot of formal programs that you can do, like a 1 year kind of bridge program. And those are also super, super helpful because they're very medical focused. But I had to do like the basic, some organic chemistry and biochemistry. So I went to just a standard UT college, and I guess they let me do it. So it worked out.
All righty.
How much
How
are
often are backup shifts, and how much before are you notified?
Yes. It depends on where you work. So there are some places that don't have backup shifts at all, and they kind of just rely on your colleagues. Like when you're sick, you hope someone takes your shift for you. So there are a lot of places there are some places that don't have backup shifts. My backup shifts, I usually have 1 to 2 a month, I think. And I've only actually had to be called in one time, and I knew the night before because my colleague was very sick, and so I was like totally aware I was getting called in. And I'm lucky because I work at a place where you also get extra pay if you work the backup shift, which is kind of cool. So, plus, we all work really hard, and nobody abuses the backup system. So like if someone can't go to work, it's because they're sick or something serious has happened. So we all feel pretty comfortable covering each other when we need to. The only difference is I just, I know I can't go out of town or something that weekend because I have to be available. Usually you
Right.
get notified ahead of time, but it can be like, anytime, like if the shift starts at 10 p.m. and the doctor gets sick on the shift, they could call you at 2 in the morning and be like, hey, we need you to come in and cover. And that's part of kind of knowing that that's part of my job. Most jobs that work in a hospital have some sort of backup call or some sort of system.
Right. And this is a question which I guess got asked through YouTube or directly to Nicole. What did your weekly, monthly shifts look like as soon as you began your job as a doctor?
So as a supervising doctor, as an attending, this is my first job. So these are how my shifts look. When I was a resident, yeah, yeah, it's kind of great. When I was a resident, residency is totally different. It depends what you do. My job as a resident was pretty crazy, fresh out of medical school, because I was at one of the biggest top children's hospitals in the world. And so it was very, very, very busy. I worked very hard all the time, but I learned a lot. And I knew that was a place I wanted to go because I wanted that experience for myself. You'll get a great education wherever you go, but I think you just have to know what you're looking for yourself and for your career, and kind of what kind of work-life balance and all that sort of stuff when you're a trainee. And you just gotta kind of reflect on what's right for you.
Hey, back to the open Q&A list. Elisa has a question. On average, how many other doctors performing the same job as you
Are there normally?
are there normally? I had a hard time interpreting that.
Mhm.
If you're busy with one patient, do there happen to be other doctors who can make the callers at all on you?
I gotcha. So, it depends on where you work. I work at a level 1 pediatric trauma center. So that means we can see every single sick patient. There's nothing we can't do. Anybody that comes in getting CPR from a big car accident, anybody that needs an emergency surgery of any kid's age, we have the staff and the team to take care of them. So at level 1 trauma centers, there are usually multiple ER doctors in the ER to take care of these patients, because there are often times when there is more than one life-threatening emergency and they need a supervising doctor to take care of them. So at my job, pretty much there's only 2 hours in the day on some days where I'm the only supervising doctor. The rest of the time, there's always at least one other supervising ER doctor there. And then most of the time there are 3 or 4 of us there. And then also we have, the fellows are there. So if for some reason there's not another supervising doctor, the fellow can also help run that trauma or that code. And then we have the trauma surgeons who can run the trauma if there's big trauma. And we also have the ICU doctors, so the intensive care doctors. If there was a time when it was like 7:30 a.m. in that 2-hour block where I was alone, and I knew there was another like code coming and I was planning to run 2 codes at once, I would call the ICU doctor and be like, hey, I need help. I need you to come down. And they're more than happy to help. So most of the time I'm never alone. And there's always a resident, a physician assistant, or multiple residents, physician assistants there too. And they're all awesome too. So they can also stabilize the patients too. And sometimes you can like pop back and forth, but that hasn't really been an issue. There are some jobs if you work at more like community sites where it's not like the big level 1 trauma center, where you might be the only doctor. You might be the only pediatric ER doctor. And it can be scary and it can be challenging when you're by yourself and you have 2 really sick kids come in, or even 1 really sick kid come in when you don't have all those other teammates. And that's kind of something you have to think about going forward.
Right. Does the doctor have to memorize the emergency phone call that you get from the ambulance coming in, or is there a recording automated note taker to assist?
Good question. Both. There is usually recording, but there is also a note taker. I listen to the call when it comes in real time, so I can get the information. And if I have questions for the ambulance team, I can ask them right then to help prepare our team. But both. Most of the time there are recordings, and then there are also there's also a note taker. But we also remember it. It's pretty quick. It's like just kind of like that brief thing that I gave was pretty standard for a big call. The other calls are quite shorter. They're like, we have a kid with a cough and a fever. They're 3. Everything is normal. Their vitals are normal. We'll be there in 25 minutes. And I'm like, okay, that's easy, But the big emergencies come in like that call, and we usually remember them. But
right. And so when the perfect storm happens, you clearly are a very positive, energetic person. How do you stay that way when you've got the perfect storm, whether it's multiple complex patients or one really heartbreaking patient who may not survive? How do you keep the bright side?
It's hard. I think it's interesting. I appreciate this comment because I am generally a very like upbeat, energetic person, but I have been told that when the codes or the traumas come in, I am like serious, straight, let's do it, get it done, which I think is from training, right? We train and we practice and we learn. And I've had great teachers to teach me how to, mind on we're doing this. And I think in those moments, you have to be very serious. And you also have to be respectful of sometimes the way we cope is by like joking with our colleagues or laughing, but you also have to be very respectful that this is like the scariest time in this family's life. And so we can talk about all of these like lighthearted moments or ways that we could have done things better like after, but in the moment we have to be serious and like eyes like on the job thinking about these patients. It is hard. Like this is a job where kids die. And it's hard. It's terrible. I cry when I lose a child. I cry with the family. I cry in the room. And that's part of the job. And I think everybody copes a little bit differently, but sometimes I'd send a card to the family. Or you find ways to cope. But the thing is, you just have the perspective that you do everything you can for this child. You do everything you can for this family, and with or without you, without you, they would have had a different outcome or maybe the same outcome, but you just do your best. And I think you just have to know, like, at some point, everyone dies, and these kids just die earlier. And I don't know why. And I don't know that, there are people who find comfort in like religion. I'm a spiritual, I'm not a very religious person. But we find ways to cope. We do a lot of debriefs. So after we have these big events, certainly when there is a death, we all take time away. We go sit in a room and we talk about it and about the things that happened. And then often in a week or 2, we do another meeting and we talk about the things that happened and how people are doing. And then we have chaplains who chaplains, we have therapy that's free for employees. There's lots of teammates who check in, we check in with our fellows and our residents. And even when kids don't die, like sometimes people are really upset and they scream and yell at you. And this is hard to cope with too. And you just have to find ways to cope. But I think I cope with knowing that like I gave everything I could for this family and for this child. And I will have another experience where it turns differently and I'll be happy that I was able to change this. And I always make it a point, every single case where I lose a kid, I learn something new and I take it to the next kid, And so I think it's hard. It's really hard. And I'm not always positive all the time because it's tough because I'm a human, right?
Right. I'm going to generalize this next question a little bit. So how does a parent guardian detect if their child swallowed anything that they shouldn't have swallowed? Are there real obvious keys, behavior change? Is there anything you can offer there?
It's tough. I mean, often you don't know. And that's part of like, sometimes they're like, I don't know, my kid says their tummy hurts and this just started randomly. I don't know what's wrong. And I'm like, okay, well, I use my training and my experience to figure out like, what's the right test to do and, what's going on. Some kids will like, be like, 8 battery, or like the parents will like look at the toy and they'll be like, this toy's open, but like, where's the battery, but there's kids drooling, stuff like that. Then you're worried they put something in their mouth or they swallowed something or have something in their airway. Sometimes you don't know. You just
Right.
don't.
What's it called when a child eats a lot of their hair and that leads to an impaction? I understand that's sort of special joy.
I've had one of those actually. Trichotillomania. So they eat their hair and they get a hair bezoar, but it doesn't have to be hair. Like there are kids who eat a lot of things, like people eat yarn, stuff like that. And then we find it later and then they have to get it taken out, but surgery.
And then you knit a mitten. Anyway, so you do a lot with one shift.
We knit it. You made me laugh. I got it. It took me a second. I got it.
You do a lot with one shift. My question to you is, what would allow you, and this is a great question, what would allow you to be more efficient with space for you to catch your breath? What in the system could change that benefits the patients and make your life easier?
Oh, this is a good question. So, there's actually things that have been shown to improve efficiency, and I am sometimes not good at them, and that's honestly on me. The things that have been shown to improve efficiency are actually taking 5 minutes for yourself and going to the bathroom, eating dinner, taking a break. So I try to be good at it, and some days I'm really good at it, and some days I'm not good at it. But that's the one thing that's been shown to improve efficiency for a physician. I think it's tough. Everyone has their different workflow. Part of being efficient is like getting all your notes done on time. Again, sometimes I'm really good at it and sometimes I'm not. And it totally depends on like, if I have a family who needs extra conversation, or if I have a transfer call that I have to give a lot of advice to, it totally depends. But there are a lot of things you can do to be more efficient. And we all, I think every ER doctor I talk to has different struggles in that area. But system space, that's tough. I think a lot of it is having like, getting patients through the system quickly, getting them out of triage and out of the waiting room. And sometimes we just don't have enough rooms, or we don't have enough nurses, or we don't have enough CAT scan machines. There's a lot of things. And I think kind of just depends. Yeah.
Is artificial intelligence going to ultimately help things out or put people out of work?
Oh, I don't know. I'm not a tech person, and I really don't use AI. There's a lot of AI that's actually being used with permission from families to like record the conversation and put it into the notes. And I find that that's really interesting and something that I am going to explore eventually, I think. I think there are some jobs that AI may be coming. I think, luckily for me, I think you always need hands-on people in the ER. And it's funny. I've seen some of the cases where like the ER, like you tell them the symptoms and AI diagnoses it. But almost every single one I've seen, actually, I think of many other things that are more common that the child would be likely to have. And so I think there is probably a place for AI, but I don't know. I think some jobs potentially it could help, maybe like reading images, x-rays, radiology stuff. But I think luckily my job's pretty safe because you always need that hands-on like provider intuition, which is cool. But yeah, it's
Right.
kind of
And just reminding folks, we don't respond to the raised hands. Please put your question into the chat. I'm going to combine two questions here. What classes did you take in high school? And what was the process like for applying to college? And combine that with, did you take any college classes while in high school? And, how did you prepare? And from what I recall, this was not your perhaps original direction, so a little bit of this might not be relevant, but they're the two questions.
Yeah. So it's funny. I thought I was going to go into college and do like biology, and I ended up doing political science. I just had a random change because I thought it was really interesting. I love to read. I wanted to learn about the government, but I kind of always thought I would end up in healthcare some way, shape, or form. High school, I did your normal standard general education classes, and then I did a lot of soccer playing, so in a soccer team, and I did do a fair amount of AP classes. So I took like oh my gosh, I'm dating myself. It was a long time ago. I think I took AP Bio, AP Calculus, AP English, and then while I was a senior in high school, I actually did take a fair amount of classes at the local community college that gave me credit for college. So I finished high school when I was 16, which was cool, and then got a lot of credit for college classes too, which was nice.
Right. And then back to the, very specific question of, managing the pace and the potential for, the unfortunate adverse events. Have you yourself ever faced a period of burnout where you're just like, I need to take a week, I need to get away?
I think the pace is fast. Usually the pace is fast. Most of the time we're very busy and there's always another patient to be seen. Sometimes there's not, and when there's those days when all the kids are healthy and it's kind of awesome because I'm like, oh, this is cool. I can connect with my staff. I buy my team breakfast. Like it's nice. We get to bond and have coffee, and those are very rare, but they happen. Snow days. The pace is usually fast, but I think the thing is it's fast, but in the sense that there are like always people to be seen. But in the pediatric world, there's not every single patient needs life-saving intervention like CPR. That's not as common. If you are like super into that, you get a lot more of that in the adult emergency medicine world. In the kid world, we get like a big medical response at my place, maybe like once to twice a day max. Of course, there are days when there are more, but it's not always like all day, every patient. So those are really fast, but otherwise, I still think, yes, we see lots of patients and it feels fast because there are lots of people to see. But I still take the time with the families and the patients because you want to make sure that you're treating them well while they're there and you're doing all the right things. Like all doctors want to do a good job. We go into this field because we care and we want to make a difference. And so in those moments, I really like when I'm outside the room before I go in, I learned this from a great mentor. I actually take a big breath and a moment and I set the tone for like how I want to go into the room. So even if I've had some like frustrating thought about some interaction or something that happened, I try to focus on the patient and the present moment that I'm about to go in. And sometimes that takes like, I need 2 minutes. I'm going to go get some water and then I'm going to come back. So that's kind of how I cope with the pace. And then burnout, yeah, I think burnout is a real thing in any field, I think. I think it's very hard, and especially as an ER doctor. Pediatric doctors actually have one of the lowest rates of burnout. And I don't know why. I think like our patients are so adorable and cute, and like when you're fixing them, you're doing awesome work for the cutest little people, So pediatric ER doctors have a significantly lower rate of burnout than a lot of other doctors. But yeah, I mean, we all experience burnout. I think there are days like there are weeks when I'm like studying for boards. I have 4 research abstracts due. I have presentations to give. I have 3 teaching opportunities I've signed up for. And I've can't exercise for an hour like I want to. I can't exercise at all that day. I pick up food from a restaurant instead of making the healthy food I want at home. And that certainly happens. And for me, those are like burnout symptoms, is when I'm not able to do those things to take care of myself, like exercise, walk my dogs. But I think I also recognize, like, it's okay. It's one day. There will be another day where I'm going to have more free time, and the world is not going to end if I don't get to work out. Like, I don't get to exercise. It's going to be okay. And so sometimes that means, like, I have 30 minutes of my day, and instead of doing exercising for that 30 minutes, I sit and watch a Netflix comedy with my husband. Like, you know, and I think you just have to know yourself. Burnout's real. It happens all the time. It's not even if you're in a career for 15 years, right? Residents get burnout, medical students get burnout. I think you just have to find healthy coping mechanisms. I don't know if
All righty. And I'm going to answer one, just starting to answer one question so we don't have to ask it. Oh, yeah. So you mentioned teaching some newer practitioners that are in the meeting, and you made me wonder, what kind of beginner mistakes do you usually find new physicians and perhaps new PAs and new NPs doing, and what can be done to avoid them other than experiencing the learning, process?
Ooh, mistakes when practicing, new mistakes for new providers. I think I have an answer, but it kind of goes both ways. I think new mistake can be being too confident or not being confident enough, to be honest. I think it's a balance. So I myself found that when I transitioned from being a trainee to an attending, I was very confident as a trainee. I was like, I'm super well trained. I know what I'm doing. I got this. And I think in the back of my mind, always knew there were people watching me, right? And then you transition into this faculty attending role, and you're like the boss, you're the supervisor, whether you're a PA or not. Like, it's your patient you're seeing, you're the PA, it's your patient, right? I'm the doctor, it's my patient, and I'm ultimately responsible for them. And so it really makes you think, like, oh, I could miss anything. And so that, I think, like, having to give yourself grace and realize this is a transition period, and I trained hard for this, and I know what I'm doing, and taking time before I'm sending these people home and really reflecting on how I feel about this patient leaving, or how I feel about this decision. And if I feel like, okay, I feel like I'm going to be able to rest at night, that I did a good job, then I'm okay. I did a good job, and that's what I trained for. And I think so that's like what we call imposter syndrome. I think a little bit of imposter syndrome is healthy, but I think also you can have too much of it, so you're not able to function and do your job. And on the other side is like being too confident, like knowing. I always get a little nervous when I have like a first year trainee who never asks me questions. Like, that's weird. You should know that you don't know everything, and that we're all learning. Like I said, I learn new things every day. I learn things from my colleagues all the time. And I was like, this just blows my mind. Like, I didn't even think about that, So I think not asking questions and not recognizing that this is a field where people's lives are at stake, and that we always learn, and nobody can know everything, no matter what. Even if you're the supervisor of the supervisors, you don't know everything. So I think not asking those questions when you have people around who can help you, kind of, I think that
Right.
for any field, honestly.
Down to the last three questions, and I think you actually addressed the one, when you have to face the loss of a child while practicing, how does that affect your mentality? And you really told us what you did and what you and the team do to, bravo to you for being able to cry with the family. That's got to be a big advantage, to feel comfortable doing that. Bravo to Nemours for supporting team time to take a minute, just a minute or three, and just go, wow, that's but are there any other particular, things that you do? What, like when you go home, do you talk with the dogs or your husband, or
Yeah. I usually get myself something delicious for dinner. Like I'm like, this is the day I'm eating fettuccine Alfredo because I deserve this and this is my happy food. I do that. I usually try to go home and I really just like sometimes I cry at home. But I usually watch something happy or we, do something fun, go bowling, something like that. Those are the things I do. I think it's very important. Many of you should not be drinking, but I think it's important to like recognize the appropriate ways to cope, right? So like going home and doing healthy, like exercising or going on a walk or like playing with your family, doing healthy coping mechanisms helps you process those losses, I think. And so those are the things that I really focus on is like not doing those other unhealthy things like
Right.
mind things.
I think that just about all of the self-medicating coping strategies are probably not.
Yeah, I think like a lot of it's like we see that on a lot of TV shows, right? That's like what people do. They like go home, I need a glass of wine. And I think for me, I really try to focus on not doing any of those things, and really focusing on the things that bring me joy because they're sparking life, right? So like doing things with my dogs and my husband and like bowling or like going out to a nice dinner or something like that, because these are like communication conversations I can have while I'm doing that stuff. I don't know. It's just my
All
coping.
right. Last two questions, and folks, please don't put any more questions in the comments. The line has been drawn in the sand. There are cases when a healthcare provider claims it is something either urgent or needs acute care, then maybe the patient goes to another doctor and they say it's something else. My question is that, can a healthcare provider get in trouble for an incorrect diagnosis? I have heard of similar cases.
Yes. I think like if we're talking like legally in trouble, I think that's always something you think about when you're in a very what we call like a litigious field. So emergency medicine is a highly litigious field. Pediatric emergency medicine is actually not as much for sure as adult emergency medicine, but like all these like a lot of surgical specialties, there's a lot of complications and these are things that like you cannot predict and that you can't fix, and it would have happened no matter what. So yes, you can get in trouble legally for an incorrect diagnosis, and you can get in trouble with your job if you make an incorrect diagnosis. Typically, these are cases when something life-threatening, limb-threatening, long-term quality of life affecting things have happened. So you miss a big meningitis and this kid goes home and has brain damage forever or something like that. Those are things certainly you're going to get in trouble for, but it has to show that you did not practice the standard of care. So whatever you did was outside what the average other doctor in your field would have done. And those are not as common. I mean, people say lots of people make lots of claims about things for any field, but you have to, the doctor has to have done something that was outside standard practice. Otherwise, if it's little things, I mean, sure, the families theoretically could like write a bad review about you or say bad things to other people about you, but things that would really affect like your career or your ability to practice medicine are usually those things that are like really big, like you missed a big appendicitis, a kid got super, super sick and died, something like that. And those have to be, though people can bring a case against you at any time or a malpractice, they can like report you to the medical board at any time. Theoretically, you're not gonna lose your license or anything unless you practiced outside the standard of care.
Gotcha. Okay. Last question. And I saved this for last because it's so great. Looking back, what advice would you give to your younger self?
Ooh, how young are we talking? Younger self. I think looking back, I think I would say all those things you are like, I'm going to do this when this happens. I'm going to go on this trip when I have this much money, or I'm going to go on this trip when I have this time off. I think do those things now. because it's never the right time and there's always more things that come up. You know, there are like lots of trips and weekends and things that I wish I had gotten on that I was like, when I'm done with all my training and I like have the time and I don't have all these responsibilities, I'm going to do this. There's always more things. Life brings lots of things to you. So I think doing the things in the moment like that you are waiting for the future. And then I think it's like learn something every day. Like everyone makes mistake. We make a mistake every day. So when you make a mistake, be the person who takes the time at the end of the day to think about it and reflect on it and make that part of who you are, because that will change who you are, how you communicate with other people, and like who you become, you know? And I think being able to do that when you're young and really reflect is the thing that is going to make you successful in life.
Right. Well,
I saw a brief pop-in of therapist. Can I answer that question real quick?
sure.
So, do I feel like I need to talk to a therapist? No, because I'm a talker in general and I talk to all my friends and family as therapists, but I think everybody honestly should probably have a therapist. All people in every field and every part of life have things they cope with, and I strongly advocate. I don't see a therapist because I feel like I just don't have time, and honestly, I probably should. We all should, to be honest. I think every human at all age of life should, because it's really nice to have someone to just listen and talk to and give you different perspective. I'm a strong advocate of therapy. I advocate it for all my patients and all my families. So I think yes. And I think it can be a really, really healthy way to cope with life, not just because I'm a doctor and I deal with death all the time, but because like life is hard, right? Growing up is hard, being an adult is hard. And I think it's important it's a healthy coping mechanism. I think therapy is awesome.
Absolutely. Well, thank you for truly a memorable presentation. So next week, I'm not even sure how I can say your colleague's name. Dr. Odira
Oh, I don't know.
Oh, anyway, he is a pediatric intensive care doctor. So this week you've heard from a pediatric ER physician. So now we're going to go out of the ER into the intensive care unit. Again, thank you so very much. Thank you for sticking in there with us right to the very end with handling so many questions. And we will
email me. You all can email me anytime.
Oh, great. Somebody asked that. So if
Yeah.
so I've got your permission to share
Totally.
your email address.
Amani.Sanchez@nemours.org. Anytime. Happy to chat about
right.
anything.
Okay. Good night, everybody. Bye-bye.